Morning, good afternoon, and good evening to everyone. Thank you so much for joining today. Our webinar today is on physiotherapy in CDKL5 and other genetic conditions. Our guest speakers are Ms. Lauren Sang and Ms. Pauline Chuang. Thank you so much for coming to our webinar and uh, helping us understand the physical therapy related problems in genetic disorders, as well as how we can work on resolving them. I'll give a brief introduction of you two, and then we can get started. So I'll start with Lauren. Uh, Lauren graduated from Weston's. Also, just letting everybody know, this meeting is being recorded, and I'd request all the participants to please mute yourselves. And if there are any questions, please put them in the chat session, and we can take them up towards the end of the webinar. We can take up all the questions at that point. So yes, Ms. Lauren graduated from Western Sydney University with a bachelor in physiotherapy and is the lead pediatric physiotherapist at Moby Kids located in Bella Vista. She is a dedicated pediatric physiotherapist with deep passion for en enriching the lives of young children facing developmental delays and rare genetic and neurological conditions. And Lauren discovered her calling providing early intervention to young children with disabilities, particularly those aged 0 to 5 with complex physical and neurological presentations like cerebral palsy, spinal muscular atrophy, congenita, etc. These are similar in symptoms to CDKL5. Committed to staying abreast of advancement in her field, Lauren pursues continuous learning and professional development. She holds specialized certification in CME and TASES. TASES is task-specific electrical stimulation. She's level 2, allowing her to tailor therapy sessions unique to each child's need. Outside of Moby Kids, she uh, loves playing tennis and cooking. Welcome, Lauren.
Thanks, Janu.
And also we have Miss Pauline. Miss Pauline is a senior pediatric physiotherapist at the Napa Center. She holds a bachelor in kinesiology from University of British and a master of physiotherapy from University of Sydney. Her expertise expand from neurological disorders to acquired brain injuries and childhood cancer. She thrives to create a supportive, engaging, and fun environment to help kids reach their fullest potential in a collaborative manner, tailoring therapy to each child's unique needs. She believes in empowering families through education and involving them in therapeutic process, ensuring that progress extends beyond therapy sessions. Beyond her clinical practice, Pauline volunteers at Ocean Heroes and is dedicated to continuous learning to stay abreast of latest research and advancements in pediatric physiotherapy. With that, I would hand it over to Pauline and Lauren. Please take it from here.
Thank you, Janu, for our introductions, and welcome everyone. And thank you so much for giving up some of your time on your weekend to join us for this seminar. Today, our seminar will be on physiotherapy in CDKL5 and other genetic conditions. So as I said, I'm Lauren, and this is...
Hey everyone, Pauline.
All right. So during today's presentation, we'll be going over what is muscle tone. So what is the difference between high tone and low tone? What is the difference between muscle tone and muscle strength, which is often confused? Commonly seen risk factors that we see as physiotherapists, so scoliosis, hip dysplasia, foot deformities, and how to manage them. Other beneficial modalities such as hippotherapy, hydrotherapy, race running, and adaptive bikes, which are lots of fun, and some exercise ideas that you guys can implement in your home environment. So we'll teach you how to do that. We also will have time at the end to answer any questions that you have. If you do have some questions, as Janu mentioned, just pop them into the chat and we'll go through them at the end. So to start off with, let's talk about muscle tone. So what is muscle tone? It is the amount of tension or resistance the muscle has at rest. Now, we all need muscle tone for us to maintain our posture and be upright against gravity. We can feel muscle tone on ourselves. And if you have someone next to you, we're going to get you to try and do it on each other, as it's much easier. But if you don't, you can try it on yourself. So let's try and feel muscle tone through the calf muscle. So if you're sitting, you might need to bring your leg up. So everyone grab the top of your ankle. And with your other hand, what I want you to do is kind of cut just underneath the toes like that. And I want you to relax as much as possible. Remember, tone is passively felt. So if you're resisting, you're not going to be able to feel that. Let your hands do the work. If you have someone else, then do it on each other. Now bring your toes towards your shin. This baby's not going to let me because she's completely rigid, but you should be able to. And note what you're feeling. What you should be feeling is a slight resistance, even when you're completely relaxed, and that is your tone. Individuals with CDKL5 have a decrease in that tone, or therefore they have decrease in that resistance when we move their limbs passively. In the next few slides, Pauline will now go through muscle tone in more details.
Okay, so what is normal muscle tone? So everyone has tone in their muscles, but it is important to know that muscle tone is a spectrum from low to high, and in the middle, what we consider as normal. Normal muscle tone means that we have the just right amount of tension in the muscle at rest, and we're able to switch on the muscle efficiently to initiate and perform any activities as needed. And because muscle tone is a spectrum, a child who has low or high muscle tone can be impacted differently. So for example, for some kids, their tone may not affect their functional movements as much, whereas for other kids, it can significantly impact their posture, their independence, their participation in daily tasks and activities. Okay, so we're now going to talk about hypotonia. So with that spectrum that we're talking about, hypotonia, which is also known as muscle tone, it's on the lower end of that spectrum. So hypotonia is also known as low muscle tone. It is used to describe muscles that are floppy or to relax. It is therefore then more effortful for children with hypotonia to activate their muscles and be able to move in an efficient manner. Not only are movements difficult to initiate, but even like static position, like us sitting right now and maintaining that good sitting posture and standing for long periods of time can also be very challenging. Low muscle tone is often, but not exclusively linked to genetic or chromosomal abnormalities. Other than CDKL5, some other diagnoses where hypotonia is a main characteristic includes, is not limited, Prader-Willi syndrome, Down syndrome, autism, and Joubert syndrome. Okay, now we're going to talk about the other end of the spectrum, which is hypertonia. Hypertonia is also known as high muscle tone, and it is used to describe muscles that are very stiff or rigid. Because of that increase in tension or increase in that muscle tone, it makes it very difficult to move. Hypotonia commonly affects the arms and legs, so it can be all four limbs affected, so both arms and both legs, or it can just be the lower limbs, or it can just be one side of the body. For example, one arm, so the left arm and then the left leg. Our muscle tone is usually regulated by signals that travel from our brain to the nerves, and the nerves then tell our muscles when to contract to perform a movement and when to relax. In hypertonia, these signals are often damaged, and this is usually caused by trauma at birth. So this includes lack of oxygen at birth, injury to the head, and also premature birth as well. It can also be caused by stroke, brain tumor, and even near drowning accidents. Okay, so we're going to be demonstrating basically what muscle tone is and what we just talked about. So right here, we have a piece of elastic band. This is, we're just going to be demonstrating muscle tone. So the elastic band here represents the amount of tension in the muscle at rest. So normal muscle tone means that there's a tiny bit of tension here. And then high muscle tone means that there's a lot of tension, as you can see. And then on the other side of the spectrum, low muscle tone means that there's no tension at all. And because of this, it is so much harder to fire our muscle or to turn on our muscles to prepare for any action or movements. And these are just some of the impacts of hypotonia. So the first one of the impacts includes insufficient breathing pattern. So instead of using the whole entire diaphragm to breathe in and to breathe out, children with hypotonia tend to have shallower breath. So basically only using this top half of their chest to breathe. Another impact is speech and swallowing. So low muscle tone not only affects the trunk, arms, and legs, but also affects the muscle around the mouth as well. And this can often lead to fatigue during eating or difficulty forming sounds with their mouth. And therefore, it can also be kids with hypotonia can also be at greater risk of aspiration. The next one is digestion. So because of hypotonia, mainly because of that weakness around the core muscles, it can lead to slower bowel movements, which can often lead to constipation. The next one is poor posture. So kids with hypotonia usually have something called lumbar lordosis. So this just means excessive arching of this region right here, so the lower back. This is very common. So rather than relying on their core muscles to be upright and stand in good alignment with a good posture, they often rely on ligaments and bones to hold them upright. The next one is delayed in gross and fine motor skills. So it is so much harder for children to switch on their muscle, and as a result, it may take them longer to reach any gross and fine motor milestones. Another impact includes reduced grip strength, and then as a result, it makes it difficult for self-feeding and holding toys. Another impact is reduced upright stability. So a lot of kids with hypotonia, what we often see is that knee hyperextension. So what does hyperextension mean? So basically means that the knee joint is basically straightening or extending beyond its normal range. This is very common. So with kids, especially with kids with low muscle tone, they'll often walk out at that knee joint to try and find stability in standing. And last but not least, there's mobility and endurance is also impacted as well. And this is because it's more effortful for children to activate and move in an efficient manner. Okay, so what is muscle tone and what is muscle strength? So this is a very common question that we get from parents. So muscle tone is the level of tension of the muscle at rest, whereas muscle strength is the amount of force a muscle exerts against resistance. So you can almost think of strength as something that's active and then tone as something that's passive. Gaining strength will not increase muscle tone. So although we can't really change the makeup of each muscle or the muscle tone, we can strengthen the muscles to build stability, which is the key foundation for upright mobility.
So in this next section, we're going to chat about 3 commonly seen risk factors we look out for as physiotherapists when we're evaluating a child with high or low tone, and how are we going to manage it. Pauline and I thought this would be a really important area to chat about. So as parents, you are informed of what we're screening for, why we're screening for it, and what can be implemented to help your child. So we're going to first start off with scoliosis. So scoliosis is a sideways curvature of the spine greater than 10 degrees. Now, there are 4 types of scoliosis. The first one is idiopathic scoliosis. It's the most common form of scoliosis, and idiopathic meaning unknown cause. It occurs actually in 80 to 90% of healthy adolescents. The second one is congenital scoliosis, which is when the spine does not form properly before the baby is born. The third one is syndromic scoliosis, which is a type of scoliosis associated with another condition. For example, Down syndrome, Ehlers-Danlos syndrome. And the fourth one is neuromuscular scoliosis, which is a direct consequence of an underlying muscular or neurological condition. This is such as cerebral palsy, muscular dystrophy, and spinal bifida. This results from a lack of muscular control caused by neurological or degenerative muscular condition. While this represents a small amount of the total scoliosis cases, this form of scoliosis often results in some of the more complex and extensive curves. So as physiotherapists, we can assist with screening for scoliosis and recommending when a spinal X-ray may be warranted. So there are different levels of severity of scoliosis based on the degrees of curvature. So we've got mild, moderate, and severe. So mild is less than 20 degrees, and that degrees is known as the Cobb angle. Moderate, which is between 25 to 40 degrees. And then for severe scoliosis, it's around 50 degrees or greater. So if the spine was curved, it's that angle that it comes at. Early detection and intervention is really important. It's imperative, especially in the growing years. Moderate and severe curves may increase in the adult life on average 15 to 30 degrees, which is massive. This can often lead to pain, postural deformities, and gastrointestinal issues in the future. And in severe cases, it can affect lung function. Often this leads to surgery. So physiotherapy management for scoliosis. So for physiotherapy management for scoliosis, we need to be thinking about 24-hour positioning. Part of the idea of 24-hour positioning is the child will have postural supports to ensure that the body, including the spine and the hips, are in a neutral position. And we need to be thinking about positioning not only during the day, but also at night. So does your child have good positioning during the day? Does your child have a good positioning during the night? Or are they curled up in a way? Or are they sleeping on their tummy with their knees tucked? This may include supportive seating. An example is the blue seat in the middle of your screen to help achieve sitting balance and allowing the child to free their arms to either self-feed or play. If you look down the bottom, there's supportive spinal orthoses. So these include something like a DMO, which has panels stitched into it and they're tailor-made, or second skin, which can have boning for more severe cases of scoliosis. To ensure they're assuming a good posture throughout the day if they're not in a chair. Braces such as the TLSO brace, which is on the bottom right-hand corner, and braces are used for more severe scoliosis. And at night, you should be thinking about things like a sleep system to reduce the body from adopting poor postures or even that banana shape, which I think a lot of kids with cerebral palsy end up getting. So you end up becoming like that windswept deformity where their trunk goes one way and their legs go the other way, like a C shape. And with CDKL5 kids, I also noticed that they always like to sleep on their belly with their knees tucked. So making sure that those hip muscles at the front don't get really tight. So while supporting seating is usually recommended and tried by an occupational therapist, physiotherapists can help with recommending the other assistive technology equipment that I previously mentioned. In addition, we can also provide core and trunk strengthening exercises, as well as muscle releases in the trunk to help maintain that straight spine. If a kiddo is always leaning to one side's going to be tight and one side's going to be elongated. So we want to even that out to have reduced asymmetries. Something interesting to understand is that while bracing can help prevent the progression of curves with children with idiopathic scoliosis, for children with neuromuscular scoliosis, bracing is only used for comfort or functional aid. And by functional aid, it's the example I gave you where supports are given so that they can sit, so that they can do more functional things with their hands or limbs. It's important to understand that the bracing treatment for neuromuscular scoliosis will not slow the progression of the curve as it can in other forms of scoliosis, as this condition affects the brain and spinal cord. There is no cure and treatment for neuromuscular scoliosis there is no treatment for neuromuscular scoliosis to permanently stop the progression of the curves. Another important thing we as physiotherapists screen for is hip dysplasia. So before we jump into hip dysplasia, let's talk about a normal developing hip so that you can understand what hip dysplasia is. So a hip is a ball and a socket joint. The ball is your femoral head or the top part of your thigh bone. And the socket is called your acetabulum, which is a groove which the femoral head should sit in. So it should sit like this, almost like a baseball in a baseball mitt, nice and snug, nice and secure. Our hip joint develops through weight bearing through our legs. And as we do that, this socket goes from like something shallow to something more rounded and deep. And this part of your femoral head or the ball goes from this to something deeper. So as you can see, it fits really nicely and nice and snug where there's less chance of that slipping out. Now with hip dysplasia, what occurs in the hip joint is that when it's not developed properly, the socket is too shallow. So instead of being a nice C, it could look a bit like that. So nice and shallow. And then what can also happen is that the ball, which should join here, instead of being in a nice, instead of being nice and flat in this curvature here, it looks nice and steep like this. So what happens is you can see there's increased risk of that slipping out, leading to either a slip partially or complete dislocation out of the joint. So hip dysplasia ranges from mild abnormality to complete dislocation. So dislocation completely out, dysplasia, it's partly out. Children with cerebral palsy have an increased likelihood of hip dysplasia. Hip surveillance allows for early detection of hip displacement in order to prevent pain, reduce function, and reduce quality of life. So when your therapist is evaluating your child, they would likely ask about your child's hip status. If your child has had a hip x-ray, most reports will outline a migration percentage. If it doesn't, then best to talk to the radiologist or the pediatrician to maybe follow that up. This migration percentage, sometimes written as MP, describes the stability of your child's hips and outlines how much of that socket covers that femoral head. You want it mainly completely covered. The migration percentage sometimes is written as, for example, 30% MP, which essentially means that 30% of the ball is not covered by the roof of the hip socket. So imagine 30% is not covered. So the lower the percentage, the greater the stability of the hip. The higher the percentage, the less stable the hip is. So if you compare like a 30% migration percentage versus a 40% migration percentage, the 40% has less hip stability. And so we have to be a lot more mindful about therapy with that. So another thing is the trend of these percentages gathered from hip x-rays over time tells us valuable information if the hips are developing well, if they're stabilized or maintained, or if they're becoming more unstable, meaning the percentage trend is increasing, like 30, 35, 40. That means the hips are not developing the way we want it to. So what can we do about it? As mentioned before, in order for our hips to develop, we need to be weight bearing through our joints. The reason for this is as we weight bear through our legs, our hip socket will deepen, our thigh bone will become less steep, reducing that risk of that ball slipping out. So for young infants not at weight bearing age, hip braces, the one you see on your left-hand side, are used as they position the head of the thigh bone to make contact with the socket. This pressure helps with the hip joint in developing. For children who are weight bearing age, what we'd like to do is we want to do lower limb weight bearing exercises, lower limb strengthening, utilizing the standing frame on a daily basis in order to give greater opportunities for that hip to develop and reduce that migration percentage. Before we move on from hip dysplasia, I also just want to note that movements that we should be avoiding for hip health is this FADIR, F-A-D-I-R movement, which is flexion of the hip, so bending of the hip, the knee turning in, so internal rotation, and the knee coming across the body, so adduction. So as you see, if this was my right leg, if I was to turn that, that's a risk of it coming out. What we actually want to do is to position the child in a B-duction, so out, flexed, and externally rotated, because that puts pressure of the the ball and the socket together, giving greater opportunities for the hip joint to develop. So that's why you see in the infant, that's the position that they've assumed. So commonly seen risk factors, another one is poor foot postures. So pronation refers to feet rolling in, causing the arch of the foot to collapse. This is something we commonly see. Children with hypotonia often have increased range of motion or hypermobility of their joints. If a child has weakness or greater range in their ankles, this leads to poor balance and instability. This generally worsens as the child gets older and heavier if not addressed. So if you think about it, when they were little, yes, they'll weight bear on the inside of their foot, which is not ideal. Now, as they get heavier, more pressure's going through there, and those structures of the foot is not made for that. So I'm going to get everyone to stand up if they can, and I'm going to get Pauline to help demonstrate for me so that you guys can understand that pronation is not just a foot problem, it is a chain reaction. So if I just bring this down. So Pauline, I'm going to get you to stand shoulder width apart. Now, Pauline, I'm going to get you to now pretend that you've got pronation of your feet, so inward rolling. So as you guys can see, if you guys can do it with her, you can feel as well the pressure through your joints. So when Pauline rolls in through her ankles, her knees then start buckling inwards, her hips then go into, her legs then go into internal rotation, so her knees are now pointing towards each other, and that puts a lot of pressure through joints which shouldn't be having that much pressure. So if I get Pauline to turn to the side, sorry, I'm doing my best to film this. Now, when she does the same thing, so if you roll your ankles in, knees go in, what you also notice is her butt also sticks out. So her bottom sticks out, her hips tip forward, and then she ends up not turning on her core. That's actually lumbar lordosis she's showing you there, which she spoke about. So again, whilst it just starts with a foot problem, it can go up the chain and cause further problems up the top with alignment. So what can we do about it? So to help manage foot postures, physiotherapists can help prescribe foot orthotic inserts, which just slide into the shoe, whether that be off the shelf or custom, depending on the severity. Orthopedic shoes, such as the shoes from Well and Able or Piedro, which is a little bit stronger in stability. We can prescribe supramalleolar orthotics, which just come above the, I'm just going to stick my foot up, sorry, Pauline, so just above here. So just above the two kind of bony bits of your ankle. And the last one is for kids who are unable to control their shank, meaning if they are walking with their knees flicking back, so hyperextending, or if they're in a crouch where they're walking with their hips bent and knees bent, an AFO may be more appropriate because it comes up higher up, just above the calf, maybe 4 centimeters below the knee. Another thing we can do is foot strengthening exercises, which help strengthen the inner foot muscles, such as calf raises, pulling them squeaks off, reaching out for something high, or picking up pom-poms with their toes and popping it into a bucket. I'm going to now hand over to Pauline, who's going to chat about alternative therapy modalities.
Okay, so now we're going to talk about alternative therapy modalities, which includes hydrotherapy, hippotherapy, and frame runners, as well as adaptive bikes. It is important to note that there is not just one type of therapy modality that is better than the other one. Research has actually shown that when one therapy modality is used in conjunction to another, that is what provides the best outcome, best results. Okay, so the first one, this is hydrotherapy. So hydrotherapy uses the natural buoyancy, heat, and resistance of the water. It helps to develop strength, enhances flexibility, improve balance, and increase endurance as well. And usually a lot of times when we see when a kid has difficulty, let's say, coming up, transitioning into a standing position in the water, they're actually able to push through their legs a lot more because of that natural buoyancy.
And it's lots of fun when
Yeah.
kids don't realize they're working so hard in the water.
Another type of therapy modality is hippotherapy. So this uses horse riding as a therapeutic tool to improve coordination, balance, and strength as well. So the three-dimensional movement of the horses, so that forwards and back, side to side, that actually mimics the normal movement of a human pelvis when walking. The movement of a walking horse produces 100 rhythmic impulses per minute. And given that movement and given the movement from the horse, this encourages the child to make appropriate riding reaction in order to maintain that sitting position on top of the horse. So that is also really good for that core strengthening as well. Okay, and now we have race runners and adaptive bikes. So race runners is a picture on the left, and adaptive bike is the one on your right. Race runners and that adaptive are great ways to target that cardiovascular endurance, that lower limb strength, and that coordination while having fun. And for those who aren't really familiar with race runners, they're also known as frame runners as well. And it is basically a three-wheel pedalless running frame that allows individual with physical disability or balance deficit to be able to run. Okay, so now we're going to talk about some home exercise ideas before we answer any questions. The three exercises that we're going to talk about, they're basically that foundational exercises that you can do at home using what you have. We'll talk about the benefits of these exercises, and we'll show you how to perform these exercises safely at home. Okay, so we have the first one. The first one is called transition to sit via rotation, or sometimes the therapists will refer to it as supine to sit, supine meaning lying on your back. The purpose of this exercise includes head control, upper limb strengthening, core strengthening, and trunk rotation. Okay, so let's demonstrate it.
I'm going to do my best to finish.
Right. Okay, so at home, you want your child to be lying on their back, just like this. Okay, so to facilitate a child to come up into sitting, I'm going to place my hands at their pelvis. So what I'm looking for is, while I turn the child to its side, I'm looking for that chin to tuck in, and then slowly weight bearing through the shoulder, pushing up through the elbow, and then a hand to come up into sitting. So you can see why this exercise is really good for that head control and that upper limb or that single limb strengthening as well. When your hand is at that pelvis, you don't want to squeeze the child too hard. You basically want to just use your hands to basically hug the child, and so that you're ensuring that you're providing that right input. So when you're doing this exercise, when you come up into sitting through that rotation, you want to, the most important thing to do is wait for the child to respond. So a lot of times when we practice home exercises, we'll see that the child just go whoa and then up. We want to slow it down, make sure that every single movement the child is initiating and participating while they transition up into that seated position. A good way to progress and regress the exercise is by holding the child at the pelvis. That is where we start, but if the child is having difficulty maintaining that chin tuck, you can place your hands up higher. So for example, underneath their armpit to come up. This way they won't have to use their core as much. They can just focus on that head control, that hand control, that arm strength. And another, so if you want to regress the exercise, so giving them less support, you can actually place your hands back down lower, so at their thigh, doing the same movement as well. Okay, let's move on to exercise number 3. Or sorry, 2. So exercise number 2 is called tall kneeling, with or without upper limb use. So the purpose of this exercise is for that core strengthening the glutes around the hips, and then also stretches the hip flexors, which is in front of the hips. Okay, so let's demonstrate tall kneeling. So we can do it at a surface or away from the surface. So this is our surface. The surface is probably a bit too high for this child. Ideally, the surface should be around chest level. So you're going to place the child just sitting on your lap. And one way I like to transition the child to that tall kneeling position is once the child is seated on your lap, you're going to use the other hand to cup their ankles. So you grab both their ankles like this, and then you lift the child up while bending their legs down like this. So I'll demonstrate that again. So seated on lap, using your hand to pull both ankles together, cupping the ankles, you're going to bring the child up while you bend their knees like this. So in this position, one way to really support the child is you can actually use your knees. So a lot of times when a child doesn't have that glute strength, they'll see the hips splaying out. So instead of having their knees underneath their hips like this, their hips are out to the side. So this is when you can actually use your knees at the child's calves to really lock them in that position. So from here, you can place the child's hand on the surface, just like that. And then you can slide your hand down at the pelvis to maintain that position. An additional benefit of this one is you can actually come down into this heel sit. So what I'm doing right here, and then transition them up into that tall kneeling as well. To make this exercise more challenging, you can take away the surface. That way they really have to use their core then to maintain that upright position. A lot of times when a child doesn't have the core strength, you'll find that once they're not holding onto a surface, the child will just flop over like this. Okay, let's talk about exercise number 3. Perfect. So exercise number 3 is called sit to stand from your lap. The purpose of this exercise, including that forward weight shift, so bringing the body forwards, switching on the core and glute muscle at the same time, and lower limb strengthening as well. So with this exercise, it can be done on a small bench if you have one, or you can also done from your lap as well, depending on the age of the child and how tall the child is. So I'll show you a sit to stand from the lap.
And we tried to pick exercises as well that required minimal equipment. As you can see, we just sourced one of my things, but minimal equipment, and if not, just using your own body to be able to do the exercise.
Okay, so with the sit to stand, you're gonna place the child on your lap, just like this. One trick is with my other leg, I actually like to put it on top of the child's foot, just to make sure that I'm really grounding that feet on the floor. And this will also ensure that when they're standing up, their knees are right underneath their hips and their ankles are right underneath their knees as well. So from this position, I'm going to bring one of my hands in front of their belly and then the other hand right at their glutes or their lower back. So what I'm looking for this exercise is before coming up into that standing, I'm really looking for that child to bring their body forward, maintaining that instead of collapsing all the way down. So maintaining that posture right there before coming up into standing. And then the same thing on the way back down. You want the child to be leaning forward slightly with their butt sticking back out before coming down into a seated position. So now we'll show you this exercise from a side view.
So thinking nose over toes when trying to get that forward weight shift. Their nose has to go over their toes in order for them to stand up and to sit down.
Yeah, exactly. So the child seated on my lap, we're gonna go nose over toe. So bringing that forward, working on that forward weight shift, making sure that it's not too exaggerated or it's not too minimal, so just that right amount. And then we're gonna push up all the way up into standing. So like I mentioned previously, you don't want to be doing the work for the child. You really want to use your hands as that prompt or as that cue to help the child initiate that movement and really wait for their response to come up into standing.
Perfect. All right, so that kind of brings us to the end of our presentation. So we'll go to our question time. Janu, is there any way you can help us see the questions?
Yes, I will read the questions out to you and you can take your time to answer them. As a reminder to everybody,
Sorry.
As a reminder to everybody, please put your questions in the chat window. So the first one that came in is okay. Yeah, and just a quick note, like we were trying the exercises on Rena when you were demonstrating that, and like it was really great to have that demonstrative approach. Like we always miss that, so thank you for showing the exercises how to do them at home. Yes. So the first question. Yeah, so the first question is, with scoliosis in our kids, can treatment help the curve in the spine, or it just has to be surgery? Is it beyond being preventative? Like once they're at that mark, you can something other than surgery help, or it just, it only has to be surgery.
Yeah, absolutely. It depends on the type of scoliosis. So with neuromuscular scoliosis, as I've mentioned, we can't really change the correction of it. Obviously, we can try and reduce them going into poorer postures. And what we could do is to help manage it, to make sure that whilst they're assuming those postures, we're still kind of trying to maintain that mobility in the spine. So some spinal releases, some massages in the rib, doing some rib mobility. And for other types of scoliosis, if you know your child is on the lower tone spectrum or even high tone, they're greater at risk of scoliosis. And that's why we screen for it. So what you can be doing is those core strengthening exercises. So a fantastic one is the one that Pauline showed us, that transition from lying into sitting. It's a great one to do during your daily activities. So every time your child needs a nappy change, practice getting up on one side and the other side. And then, I don't know, if your child has 6 nappy changes, that's already 12 reps. So try and find those different ways to incorporate the core exercises. Again, those suits as well can help with supporting a posture. So if a kid doesn't yet have scoliosis, but they're positioning like this because they don't have those anti-gravity responses and they just kind of hang off their ligaments and bones, then if you get them into a suit, it may give them that alignment so they're a bit more symmetrical. So it stops them from getting tight on one side and elongated on the other side. Do you have anything else to add to that?
I was just going to say that that's why 24-hour positioning is very, very important. So if you think about it, you're not going to be doing those core strengthening exercises every single hour of the day.
Yep.
So the other times, whether your child is in a seated position or on their bed in a supine position, that's where that 24-hour positioning, having the right seats, having the right suit,
Prams, strollers,
yeah, even when they're lying, having the right sleep position is so crucial.
And that might be them having these lateral supports in their pram, not just using a typical stroller that means that they kind of sink into this posture. So thinking about those things and then ongoing physiotherapy for those strengthening as well. Hopefully that answers that question.
Yes, it does. And it does touch upon some other points also. So thanks for that. The next question is with hip dysplasia, can treatment lower that percentage?
Definitely. So we've probably treated some kiddos who have maybe started with like 25 degrees migration percentage. We got in early with getting a standing frame. Parents were really proactive in using it daily at a minimum of 60 minutes per day, whether that be broken up into 2 lots of 30 minutes, but very proactive in doing that, and maybe even doing 2 lots of an hour. If it's 1 hour, evidence kind of recommends an hour minimum daily. The strengthening exercises around the glutes so that the muscle pulls that hip joint in, so it's more stable as opposed to it having more range. Yeah, definitely. We're seeing really great improvements to the point where we're tracking that migration percentage, and to the point where the orthopedic team goes to us, hey, they don't need any more tracking, like 3 months, 6 monthly. We're just happy to either discharge them from the orthopedic team, or they'll go, oh, we'll just check in a year. So definitely getting those weight-bearing exercises, strengthening exercises, getting the standers and the walkers, even race runners, like getting weight-bearing through those legs can minimize that risk of surgery or that hip from worsening, especially early intervention. Like these kids are young, their bones are still malleable, so now's the time.
Yeah, and I think it's so important to note that maybe even during one of the doctor's appointment, from the x-ray, the doctor will suggest hip surgery down the road. But that's not, the only option there. I think throughout that time frame, just like Lauren mentioned, time is so crucial. And even if a child is not standing independently yet, we can slowly work on that standing posture, putting them in a standing frame, so then that migration percentage slowly reduces, and so that their hips start to develop properly.
Yeah, that's a great point. And I think with the standing frames as well, like whilst yes, we can practice standing against a couch or standing against a chair, the purpose of the standing frame is that the child is held in good alignment. So their knees aren't buckling in, their feet aren't rolling in, they actually have the appropriate supports to make sure everything is neutral. Knees are pointing straight, feet aren't rolling in, hips are not twisted or rotated, everything's nice and straight, and that's what we want to see.
Yeah.
Also, this next question, you answered it but I'll ask it anyways. So AFOs prevent pronation or help fix it? Like you answered that in the next slide when you were presenting, and yes. So if you just want to highlight on pronation and the AFO aspect.
It may not per se fix it, but it will reduce it from potentially worsening, but also protects the integrity of the foot as well. So if you imagine, if you stand up and you turn your feet in and you walk like that all day, it's not only going to hurt the inside of the foot bones and structures and muscles around there, but your knees are going to start aching, and it's going to lead to uneven wearing of your knees. So what an AFO or those supports aim to do is to bring the heel, so the back of the heel, instead of rolling in like that. So if you think of one heel, sometimes this part of the heel goes out and this part of the calf is like this. We want to keep it nice and straight and then have the arch support so you don't roll in, and keeping that foot nice and straight for it to develop, everything else to be nice and neutral. And generally when we get kids in AFOs that have been made correctly, they can do more. They can last longer because they're not working as hard and being more efficient with their movements.
Yeah. And for example, let's say if a child's standing or if a child's able to take a few steps, the AFO will actually help with that stability. And also AFO will make sure that every single step that they take, whether it's independent 3 or 4 steps, or if it's like a supportive step, for example, let's say they're walking on the treadmill at therapy, or parents are basically holding them in that position while they take steps with their legs, it'll just make sure that every single step that they take is in good alignment as well. So whenever we want to take a step in the gait cycle, you basically land with your heel first. So with the AFO, it will help create that pattern. And with that pattern, then we'll basically be using the right muscles, because our body is actually so smart and clever. Our body will actually compensate for us in order to be able to produce and do a movement. So even if we're able to do a movement, it doesn't always necessarily mean that it's done correctly and we're using the right muscles.
Yeah, fantastic point.
Yeah.
Okay, very interesting. Thank you so much. The next question is, can you recommend any exercise for CDKL5 kids for pronation? There's a child and she seems to pronate to her right foot more.
Yeah, so part of I would probably recommend for the physio to have a look at that pronation. If that pronation is structural, meaning can I borrow your foot, Pauline? Sorry. We're physio, so we're used to touching each other. So with pronation, what she'll end up doing is collapsing through and weight bearing through that inside of that foot. So this is Pauline's left foot. So if that pronation isn't able to be corrected into a more neutral position where, her shin's in line with her second or third toe, that's going to broadly speaking. Then if it's structural, there's not really much we can do about it, but maintain and probably an AFO. Maybe performing some stretches on the outer part of the foot, because if you think about it, if that foot is rolling in all the time, these structures are going to be lengthened, and the structures on the outside of the foot are going to shorten and become tighter. So maybe you can do some stretches the other way, gently just giving a release on those side, or even massaging the outside of the foot. If it is able to be held in a neutral position, doing those calf raises that we mentioned previously. Thanks, Pauline. So if I was a child, I might get you to help film. And maybe it's like if you've got a fridge and you've got magnets and they're pretty interesting, stick them up high. And what you want to see is when they do a calf raise, that their heels aren't rolling in like that. You want, maybe what you can do is you can help guide that so that's nice and straight when you reach up for a calf raise. So nice and straight when they're doing it, as opposed to letting them do this.
Yeah.
There's not really a point of them doing that if it's for alignment.
Yeah. So if I were to facilitate the exercise,
Yep.
so let's say your child is standing against a wall, their hands are on the wall. What I want to do with both hands, I'll just demonstrate with one hand because I'm holding the camera with the other. You want to basically cup their ankle to make sure they're in that good alignment. See how Lauren's knees are now turned out a bit instead of caving in. So helping that alignment first, and then especially when they come up onto their toes, you want to really correct that alignment with your hands. So you might have to put a bit more pressure on the inside, this part on the inside of their ankle, just so that they can maintain that good alignment, especially when they're up on their toes.
So turning them out, oh, that's very close. Turning them out a little bit and making sure the back of the heel, just come down to the back of the heel, is nice and straight, as opposed to them being like, I don't know how to show it. Being like caved in. Yeah, so if I was caved in, can you see? I can't do it because I don't have pronation, but this would be straight and this will be pointing outwards. So kind of like if you drew another line.
You basically want to check their heel cord right here as well. So a lot of child, when they have that pronation, this heel cord right here will basically be in that almost like C shape or that curved shape, rather than the letter I, where it's nice and straight like this.
Do you see how that's nice and straight there?
Back here.
Yeah, so that's what you want to do. That's the ideal, and that's what you want to do when you're trying to facilitate those calf raises.
Thank you. Thanks for this demonstration. I will, and I'm glad we are recording this, so I will be using this so often now. So,
we're glad.
Yes. So the next question is adaptive bike. It's about adaptive bike, and how does that help walking? And like what would be the right stage for somebody to consider getting an adaptive bike? So like in Rena's example, she started weight bearing and taking few assisted steps. So is this the right time to get her an adaptive bike?
Yeah, for sure. So usually with adaptive bike, because it is an adaptive bike, there are a lot of different supports that come with it. So for example, let's say if the child doesn't have enough core strength or that core stability, there are actually lateral supports that can basically hug and place that child in the, so that can basically place that child in the optimal position. With the adaptive bike, it'll help with that. It'll help with walking in terms that it'll help with that lower limb strengthening and endurance as well. So if you think about walking, we're taking one step at a time. With the adaptive bike, it's similar in some ways where you're actually using that one limb at a time. So you're basically working on that strengthening of that lower limbs in a fun way as well. But I would have to say that with adaptive bikes, one thing that it doesn't really work on is that pelvic stability. So with our walking, what we need to have is not only that core strength, that lower limb strength and endurance, we also want to make sure that our pelvis right here and all the muscles around it is really strong and stable. So because when you're in an adaptive bike, you're in that seated position, whereas in standing or walking, you're in that upright position. In an adaptive bike, you don't really get to work on that pelvic muscles.
Thank you so much for that. We're coming close to time, so I'm gonna go faster with the questions. So the next one is, any advice on how to protect our wrists and hands when doing home exercises? Meaning like for parents, what should we do with, so that our wrists and hands are not overworked?
That is a very good question.
We know because we use our wrists all the time.
One thing that I really like to do is whenever you're handling, making sure that your wrist is in a neutral position. So for example, this is the child's leg and I'm holding onto the child leg. See how my wrist turned out right now? See how this wrist is turned out? So that's what you want to prevent. You always want to make sure that you're holding the child with the wrist. Yeah, just like this, nice and straight. And you want to make sure that
this or like this.
Exactly. And you want to make sure that not only is that wrist part straight, but also your forearm as well. So you don't want to be hiking your shoulder up. You don't want to be dropping your shoulder. You want to make sure that the wrist all the way to your elbow is basically nice and straight.
Another thing is your body positioning is really important. As you can see, Pauline wasn't doing a sit to stand with her back like this. She was sitting on the ground, getting down low to eye level of the child. You want to be working with your hands biomechanically with your elbows at 90, shoulders relaxed. Remember, keep the load so your child close to you. The further away you are, the more pressure is going to be putting through your shoulders. The other thing that we notice when we teach parents home exercise programs is, say you're trying to do some standing with your child. What we notice as well is thumbs, not just wrists, but thumbs. Parents love to stick their thumbs up because they're like, oh, I'm getting the child up. And that is really not great for your thumbs and wrists. If they're gonna fight you, your thumbs are gonna go backwards and you're gonna end up having maybe like a de Quervain's or just not great for your thumbs. So what you want to be doing is thumbs are always going to be horizontal. So if I'm doing standing with a child, I might get you to just hold the baby's head. So if I'm doing standing with the child, my thumbs are always going to be horizontal. This is terrible for my wrists. They should be at 90, like that. Never have your thumbs up, because if they sit or they throw themselves back, that's going to cause a wrist injury and a thumb injury.
Another two things I want to recommend as well is just for yourself. As your child gets older, it's so important to do wrist strengthening exercises, especially if you don't use your wrists or if you don't do these exercises on a daily basis. So one that I like to do for my wrist is, let's pretend this is a dumbbell. You're going to basically have your forearm on a table.
It'll be a surface.
So you're basically going to have your forearm on a surface with your wrist just hanging off. And then you're going to bring the dumbbell down and then come up. Dumbbell down and then come up. And because this is a strengthening exercise, it's really important to do 3 sets of 6 to 9 reps. And then you want a rest in between those reps. Another one is holding the dumbbell this way, basically what you would do as if when you're holding your child, and then do that exercise for the top part of your thumbs and your forearms as well. 2 stretches I really like to do at home is having your wrist flat on the table.
Do you want me to be
yeah. So 2 stretches that's really good for the forearms, especially, is this. So having your the back of your hand on the table like that and just holding that. Or you can bring your wrist the other way as well. This just targets the back side or the inside of your forearm like this. So basically just holding that stretch, and you can also lean your body full backwards as well to make that stretch, to feel that stretch even more.
And with those wrist exercises, which Pauline did, start really light. Your wrists aren't used to that load. Injury happens when the load is more than what your body can cope with. It can't cope with that demand. So start with, I don't know, half a kilo ankle weights and do it. Then gradually build it up to 1. So gradually do that. And I think that's a great point of making sure that as the child grows, that your making sure that your body's nice and strong, even back exercises, if you're always lifting your child as well, you need a strong core too.
This definitely feels like a webinar topic in itself. So, we'll talk about that in a bit. Anyways, the next question is, how many rounds of each home exercises can we do in a day with the child?
How many rounds per day? Is that what the question is
Yes.
at?
Yeah.
Like how many
How
reps?
rounds of each home exercise can we do?
So ideally you want to work up to that 3 sets of 6 to 12 repetitions. So 6 repetitions total, and then 3 sets of that.
Oh, sorry, the home exercises for the children that you demonstrated before, not the parent exercise, yeah. So
Yeah, the same. Yeah,
yes,
so
okay.
exactly the same, because you're at the end of the day, you're still trying to strengthen those muscles. So you want to work up towards those reps. But we definitely understand how having a child or more than one kid is really makes your life very busy. So that's why when we suggest home exercises to parents, we try and incorporate those exercises into their daily routines and into their day. So for example, that supine to sit, instead of saying, okay, I need to do, 10 reps right here in the morning, and then 10 reps in the afternoon, and then 10 reps after lunch. Instead of thinking that way, maybe every single time you do a nappy change, you can quickly do 3 on each side, and that equals a total of 6 reps.
It really depends on, I guess, your lifestyle as well.
Yeah.
Some parents just like to do a morning session. So it really depends. And I think the other thing I wanted to mention, it also depends on what you're targeting. Pauline gave you a great range to work with, but if you're targeting strength, obviously 6 to 8, but if you're wanting to work more endurance, she mentioned the upper end of 12. So if endurance, you want to be doing more so the muscle fatigues, and they build on that. So 10 to 12 if it's endurance, 6 to 8 if it's strength.
And usually aiming for 2 to 3 sets of those.
Yep, that helps explain the whole motivation behind the home exercise, that we are trying to build it in the routine. Thank you for that. I hope there's time to take one last question, if that's okay.
Yeah,
Okay.
absolutely.
Yeah, so the question is, what position or precautions parents should take while doing these exercises for the children, especially with respect to the backs?
What was the last bit, Janu?
Yeah, especially with respect to the back, like especially like what is it that we should keep in mind with our back when we are doing these exercises with our children?
Shall we
Like back.
I think when you're lifting the child, making sure that you're not lifting them like this and hinging through your legs, you're actually squatting to pick them up. If you are with your back, again, not having the load so far away. So if I'm holding a child, I'm not going to hold them with arms straight. I'm actually going to bring them as close as possible, so that my arms at 99. The further away, that puts more tension on your back.
And another thing to know is not only just what the posture is like for your back and your spine, but also actually your lower legs as well. So for example, when I was doing sit to stand, one thing that I noticed is that I noticed that I want to keep in mind is that when I'm in that seated position, see how my body's nice and flat in the back, but not just my spine, but also my pelvis as well. So what I don't want to see is my pelvis slouching back like that, but my body is straight, because of that is still not in the optimal alignment. Another thing is especially when you're carrying your child, or let's say if you're doing your exercise and you yourself are in that toenail position or that seated position like this, you want to make sure that you have a wide base of support. So spreading your legs out, that way you have a nice wide space to work with while keeping your arms in, while keeping your back up. Same in that toenail position, whatever exercise you're facilitating in this position, you can facilitate, some stepping as well. You want to make sure your elbows are tucked in, and see how my knees are wide like this.
All right, hold on, let me get a good
view. Like
view.
that, rather than closed in like this. Yes, you just want to make sure not only are your arms in the right position, your back in the right position, but especially your pelvis and your lower legs as well.
As well as building upon what Pauline just said, if you've got a child who's really little, what I notice parents doing, I might get you to help with the camera. If their child might say it's like I don't know, a 1-year-old, 12-month-old, they would do this and they'll do stepping practice like this or standing practice like this. That's going to be put a lot of pressure on your back. So get down low like this. If the child is bigger, sometimes we may need to come up into a tall kneel position because the child's shoulders is up. Sorry, the child's shoulders, you might bring it up, is more at eye level here. Or you may need to be in a half kneel. That those are some really big movements, and move with the child. So if the child is moving, then you can shuffle. That's what we do all the time. We're professional bum shufflers. Or if they're moving away from you, I go from that L sit that Pauline showed, transition into a half kneel. So you're nice and close to the load.
Yeah, so you're moving with the child as the child is moving.
Keep the load close to your body. It's probably our best tips. And body neutral.
Yes. Yes, this as I mentioned, this is something which we may need to come back. Like there are so many things that you just demonstrated in like the last 10 minutes, and I was like, okay, I'm doing this wrong and I need to fix this now, and this is the way I should be doing it. So this is very, very, very valuable. Thank you so much for all your time and sharing your experiences. With this, we'll conclude today's session, and if if there are more like if you want to share more information, then yes, thanks for putting up your contact information there, so please feel free to reach out uh, as needed. So thank you.
Yeah, we're happy to answer any questions following this presentation if needed.
Yeah, thank you for listening, everyone.
Yeah, thank you
and
for
I hope
joining
you
us
guys
on the weekend. Hopefully
enjoy that and learn something new.
And we loved presenting to you guys.
Yep.
Thanks,
And
Jenny,
this,
for organizing.
yes, thank you. And for everyone, this will also be uploaded on YouTube, and it will be on the CDKL5 South Asia website or on the CDKL5 South Asia YouTube channel. So, I'm sure I'm going to be looking at it like several more times just to make sure I'm doing everything right. So thanks. Thank you. I'll end the meeting now.
Bye, everyone.
Bye.